Okay, thank you very much for the invitation. Vitamin D deficiency in pregnancy is common around the world. It's well known. Studies have shown associations between low serum 25-hydroxy-D during pregnancy and maternal and offspring health outcomes. And what you know is, of course, that the developing fetus is dependent on placental transfer of 25-hydroxy-D from the maternal circulation. Which health outcomes have been of interest? In the mother, for instance, preeclampsia, blood pressure, gestational diabetes, and so on, and in the child, anthropometric measures, birth weight, and influence on the skeleton. Usually, when you compare 25-hydroxy-D in pregnant women, they have lower 25-hydroxy-D. It could be, for instance, the reason could be that there's an increased blood volume during pregnancy. And what is often seen is that there's a nice correlation between 25-hydroxy-D concentrations in the mother and the child. So let's look at what happens when you give vitamin D to a woman during pregnancy and what happens in the mother and child as regards vitamin D deficiency. Here is a study from 2015, a randomized trial, and you see here that if you give 2,000 international units per day, you always get a higher 25-hydroxy-D as compared to a lower no vitamin D treatment. And you see that there is a nice increase over the pregnancy. And at the end, you see that cord blood, also there's a nice influence on cord blood at the end. So, and this is then how it looks like often. That's a nice correlation between cord and maternal 25-hydroxy-D at delivery. Then there's a study from the US when they have given large doses. 400 units is not a large, it's a normal, well, actually the normal recommendation in many countries for pregnant women. Then 2,000 units, 4,000 units. And you see that they all respond to all these on the left side to all these treatments during pregnancy, and even the lowest dose has an increasing effect on 25-hydroxy-D in the mother, and they start with a mean level of 60 nanomoles per liter. So what has been of interest during the last year is that C3 epimer of 25-hydroxy-D had been found, and it usually doesn't influence the effect from the measurements by immunoassays, but it may be included in the 25-hydroxy-D measurements when measured by LC mass spec. And it's important to know this. So it may be that the earlier results with LC mass actually includes also the epimer. What is interesting here is that the concentration of the epimer is higher in the infants than in the adults, and it's typical that it may really influence the concentration erroneously, 25-hydroxy-D concentration erroneously in the child. So here is a study where they looked at the contribution of vitamin D in the child, and what you see down here is that the epimer concentration, which in this case, when it's about children, may contribute to about 25% of the total vitamin D levels, were similar in the mothers and the neonates. So this shortly about something about what happens with when you supplement and what you can maybe find there. There are some systematic reviews and meta-analysis on vitamin D status during pregnancy or of supplementation and health outcomes. There are quite new ones, and this is from 2014. And they looked at primary outcomes and secondary outcomes, as you see here listed, and what they concluded was that there was some evidence to support a positive relationship between maternal vitamin D status and offspring birth weight. This is based on observational studies, neonatal calcium concentrations, more like, well, they are randomized control studies, and offspring bone mass, again, observational studies. But problem, of course, which is very common for systematic review, is there is a large heterogeneity between all these studies. So actually they conclude that there is no single disease area which give evidence that the use of supplementation during pregnancy is warranted. Well, this one is from 2016, Cochrane review, and what you see down there is that they say that they used only randomized and quasi-randomized trials, so it's based on trials. They had the primary outcomes were, as you see here, in both maternal outcomes and infant outcomes, and a lot of secondary outcomes, which are listed here. So the conclusion was supplementing pregnant women with vitamin D may reduce the risk for preeclampsia, low birth weight, and preterm birth. It's again a question of the vitamin D status of the mothers, they are not sufficient here, and they see here, of course, also an increase in 25-hydroxy-D after supplementation or during supplementation, but what is the clinical significance? So the results need to be interpreted with caution, and data on adverse effects were lacking in all studies. They also concluded that there is not enough evidence for a recommendation for vitamin D supplementation for everybody during pregnancy. And while there is some indication that supplementation may have some effects on the outcomes, we need more randomized trials to show that this is true. And then a few years ago, there was a specific review on vitamin D and preeclampsia, which seems to be something that is much talked about, preeclampsia, and there is a lot of studies going on actually. And they saw, as you see here, the first figure here is about random effects on meta-analysis on prospective observational studies. The lower one is on vitamin D supplementation, intervention studies. And you see there that there is a small effect on the risk of preeclampsia in both groups of studies. So the study suggests that deficient maternal serum 25-hydroxy-D concentrations increases risk of preeclampsia, and by supplementation you can lower this risk. They also say that it's insufficient to determine a causal association between these. So we need more adequately powered trials. Again. Then what may have been studied much more, or we know much more about the of a vitamin D status and the skeleton of a child. But if you start with the mother, we could say that, we could start with rickets, and we know that nutritional rickets is still a public health problem in many parts of the world. It could, of course, it can be handled easily by vitamin D supplementation. Well, it is due in many parts of the world also to a low calcium intake. But in this talk about vitamin, it's about low vitamin D status. And if the mother is deficient during pregnancy, it predisposes of development of rickets in the breastfed infant, because a breastfed infant doesn't get enough vitamin D. So in principle, if at least a child starts with a good status at birth, it's much better. And the risk increases when 25-hydroxyD in the child is lower than, well, say 25 nanomoles per liter. And what actually was mentioned in some of the systematic reviews that I showed is that there are many ongoing studies on vitamin D supplementation during pregnancy. And one of these are the Mavidos study, and this was actually published quite recently, a few weeks ago. And they conclude that supplementation of women with 1,000 units vitamin D during pregnancy doesn't increase the whole body BMC of the child compared to placebo. So it doesn't have supplementation with 1,000 units doesn't have an effect. But it's sufficient to ensure that the pregnant women are replete and it's safe. So they say that these findings support current approaches to vitamin D supplementation in pregnancy. So then I will show some results from our own studies, and we looked at the maternal vitamin D status during pregnancy and the bone in the child, or skeleton in the child at birth with PQCAR. Firstly, we see here that the mother, we had two measurements of 25-hydroxy-D, one from the beginning of the first trimester and then at birth, and then we made we could use these two as a mean. But here we see that there's a nice correlation between 25-hydroxy-D and the total vitamin D intake of the mother, and you see down there that the cord 25-D also correlates with the intake of vitamin D of the mother. But interestingly then, when we divided the maternal 25-hydroxy-D into the child's into two parts, with mothers having 25-hydroxy-D lower than 44 nanomoles per liter and the one other group higher, it was the median which we used. And what you see here on the pane A is that the gray is the mothers with better vitamin D status, that the tibia BMC was always higher, also after adjusting for different covariates. And the cross-question area in the B panel is also indicates that the bones are larger when the mother's vitamin D status is better. But however, then when we look at the down there on the BMD, you see that there's no difference. So the children had kind of larger bones, but the bone mineral density was the same, regardless of the maternal vitamin D status. We also then followed these children 1 or 14 months later, and again used PQCT to look at the tibia, and you see there that Those with high vitamin D in the mother is the white one, and the low vitamin D is the black one. You see that they have actually the same BMC. After 1 year, the cross-sectional area has increased in the same way in both groups, but it's lower in that one with low maternal vitamin D during pregnancy, and the BMD doesn't differ, but it has decreased physiologically during the months. So overall conclusions from what we know now about vitamin D and outcomes is that vitamin D status, meaning vitamin D deficiency during pregnancy, has an effect on vitamin D status in the offspring. Low vitamin D status during pregnancy may increase the risk of preeclampsia. It's again about the low vitamin D status. Low vitamin D status during pregnancy may have an effect on bone mass and birth weight of the offspring, and vitamin D deficiency in the pregnant mother should be corrected by supplementation. I don't see any reason to use high doses, of course, but already 400 units or 10 micrograms per day is probably enough. But to look at these outcomes, really we need randomized trials. And this is from the view from my summer house and in July. Thank you very much.